all yours.
Assalamu alaikum. It's my pleasure, Prof. Basil, my best friends. Thank you, Prof. Adil. Thank you, the organizing committee, for allowing me to be part of this wonderful gathering globally. And I cannot add more what added, but really it's so fascinating to know more about the cystic fibrosis. Prof. Basil, can you see my slides?
We can.
Okay.
Yes.
Thank you so much. And again, thank you for attending. It's a Friday. And mashallah, the participants are wonderful and they are stick to the points. We heard many wonderful speakers ahead of us, and there's still more to come. So I'm not going to repeat, but there will be some intermixing between the presentations as previous professors attended and presented, but what facing us in the Gulf region or in the Arab region or in the developing countries are the most important part in the cystic fibrosis. And to start with, and I'm sure all of you are aware, it is a multidisciplinary disease that involves many subspecialty, including the pulmo. That's why the pulmo are presenting the most of the lectures, and the GI, as well as nutrition, as well as the social worker, as well as the community, and so on. And the goal with the challenges is to focus on the primary takers, as well as the nutritionists, the dietitians, the school, the families, because this is really what facing or challenging in the treatment of cystic fibrosis in the Middle East, simply in the Gulf region or in the Arab countries. Before I go more, there will be some sharing slides or some presentation presented earlier by my colleague that the GI part is mainly sharing the same embryologic origin of the respiratory. And always I'm teasing my colleague in the pediatric pulmo that which is first, the GI or the pulmo. So this slides to show you that both the respiratory system as well as the gut are sharing the same origin. And that's why we cannot say what is first, is the pulmo first or the GI. I think we are both the same. And even when the clearance happen for obstruction and infection in the GI, it's following the same mechanism that occurs in the lungs. The GI, there is microvillus, there is peristaltic waves, as well there is submucosal glands, the same way in the lungs that you presented or aware of, that will clear any triggering factors in our pulmonary system. And the GI simply, the previous prof, he talked about the liver, and earlier there were more talk about the GI, and this is the gut in general speaking, but the major part we're going to focus on the pancreatic function. Liver, already you heard enough about it, and then the rest of it will be the small bowel and large colon. And this is our pancreas, how it looks like from the pancreatic tail and the head, the duct, and where the ducts will secrete the enzyme lipase as well as amylase into the small bowel, and then it will go down and works on the digestion of our food. So it is a combined exocrine and endocrine part, and there are many of those important that we need it in our digestive system. The tail part, which is adjacent to the hilum of the spleen, the body, which is horizontal and behind the stomach, the head, which is embedded in the duodenal sweep, and then sphincter of Oddi and the ampulla of Vater. And the pancreatic itself, there are the islets of Langerhans, and there are the enzymes that important and abundant, like trypsin, as well as the enterokinase that is activated by the intestinal mucosa. So this is our wonderful, small, tiny organ. It's so important to know about it, which is simply the pancreas that will secrete to the duodenum, mainly the bicarb, and then the part important, which stimulates the release of the other enzymes, which are the cystokinin. I'm not going to talk about the endocrine part because this is mainly for our colleague in the endocrine, but mainly we are talking about the exocrine part, which mainly important for the aqueous secretion, sodium bicarb, and the acinar cells, which is important for the digestive enzyme. Those combination will make the exocrine portion of the pancreas, the acinar, as well as the ductal cells. And this is again, not to repeat itself, but again, it was mentioned earlier, how the liver and pancreas duct importantly secrete the bicarb through the CFTR, and then they will neutralize the acid, which is important part in the digestive process. So the bicarb important here to optimize the pH of the pancreatic enzymes and allow the mucin to unfold so it will be more hydrated, and then it promotes the bacterial killing, and finally there will be more fluid secretions as part of it. So what is cystic fibrosis? Again, I said there are some slides will share itself. It is a multi-system disease, autosomal recessive, and there are mutations and differ from country to country. In the Saudi Arabia and the Gulf, there are different mutations, and simply we discover every time a new mutation that's unrelated what we learned early in the West, the Delta 508. So there is transmembrane conductance regulators and the chromosome 7 that important for the chloride channel. So the features of cystic fibrosis, the whole program is about pulmo, so mainly chronic sinopulmonary disease. But the GI part, which will be important for the nutritional part as well as the GI, then I'm not going to talk about the obstructive azoospermia or the electrolyte abnormalities. There is something called related issues in the cystic fibrosis, and that mainly started early in the neonatal period, which is the meconium ileus. And the meconium ileus simply will manifest itself completely obstructing the small bowel, manifests itself in the first 2 days by abdominal distension, and they need enemas unless surgery is indicated. The cystic fibrosis related disease that usually diagnosed after and later on in life, and they're mainly insulin treatment, which part that is the diabetic part. This is the whole involvement of the gut, and this is a famous picture from Walsh and Smith that every part of the involved, the GI and the pulmo will be involved. I'm not going to go over it, but the airways, the liver, the pancreas, the small gut, as well as the reproductive system, part of these will be mainly here in the hepatobiliary, as mentioned in the previous talk, then in the gut part and the pancreas. The gut part here as a GI here, that will be mainly in the small bowel, in the meconium ileus, in the distal ileus obstruction, as well as in the intussusception part. So simply, when that GI part presents itself either as meconium ileus, dominant distension, or increased frequency, failure to thrive, recurrent abdominal pain, jaundice, and GI bleed, as mentioned in the liver involvement. The nutritional part is the major challenge that facing us here in the Gulf and globally, because it is combined part, mainly malabsorption as well as malnutrition. So malabsorption will be for the fat soluble vitamin, ADEK. And for malnutrition, because of their frequent diseases and frequent sinopulmonary illnesses, so their appetite is down, and there will be more catabolism more than anabolism. Because there is inflammation, there will be more plaque, so there will be more abnormality in the absorption itself. Other related disorders that we can look at it up, mainly the meconium ileus, which mentioned early, or the obstruction that manifests as abdominal distension. I will focus here, there will be malabsorption, small intestinal bacterial overgrowth, constipation. Those can be presented in the celiac part. Those part here I'm showing in this slides also can be associated, but it's not commonly, mainly inflammatory bowel disease, celiac disease, or the frequent recurrent pancreatitis. Hepatobiliary, we had enough on the hepatobiliary part, but this is important challenge for our primary care physicians when the baby is born and referred to the hepatology center, like our at King Fahd hospital in Dammam, neonatal cholestasis. Think about the neonatal cholestasis in less than 10% of the total population presented with jaundice related to the direct hypertension. CF is one of them. So that's a challenge. The other part is mentioned earlier in the slides about the liver involvement and the chronic liver disease like portal hypertension or malnutrition and malignancy later on. So the GI part, the major problem that occur in the pancreas because of the absence of the CFTR, there will be limitation in the chloride bicarb exchange I showed you early. So the secretion of bicarb will be affected. There will be more retention of the enzymes to the pancreas. As a result, there will be destruction of the pancreatic tissue. That's mainly the pathophys in the pancreas. However, in the intestinal part, because there will be drop in the water secretion, so there will be thickening in the mucus itself, and there will be a desiccated intraluminal contents. So that will end in the obstruction of the small and large intestine. This is why there will be meconium ileus in the early or distal intestinal obstruction. In the biliary tree, we had enough about it. And in the sweat also, there will be an ability to reabsorb sodium chloride. And as a result, it will affect the sweat duct. So this is a good cartoon to show you the mechanism that will happen. There is the pancreatic acinar cells. Any insult will affect the enzymes here. The pancreatitis will develop. The majority will recover. But if not, there will be multi-organ dysfunction and pancreatic necrosis. So as a result, in the pancreatic dysfunction here, the majority of those kids will have the pancreatic insufficiency, and accordingly, the management will be affecting that one. So the management of the steatorrhea that happen here, and it will end in a major problem in the defecation, a major problem in the frequency and the consistency of the stool, and there will be a problem with absorption of the fatty food. So the GI part mainly will be abdominal distension. And if we do an X-ray film, we can see air fluid levels, we can see meconium, we can see small colon. This is to show you how the stool look like in the pancreatic insufficiency and where the meconium ileus, and this is when the steatorrhea and the look like ribbon meconium ileus in the small bowel. So the manifestation that will happen with those mainly abdominal pain, emesis, or palpable mass, and can be confused with appendicitis. Pancreatitis can be as this destructive or inflammatory, loss of the pancreatic cells, and there will be more inflammatory cells infiltrating the pancreas. The exocrine part, which is the major problem here, and I mentioned early, there will be insufficiency, and that's where we'll have a problem as a challenge. How can I tell this is in exocrine insufficiency? Simply, we will see the stool consistency. Then we can measure the fecal elastase here, and we can look at the fat absorption at the 72-hour fecal fat collection. If more than 10% dumped in the stool, that goes with fat malabsorption. Neither test should be performed pancreatitis because it can misdiagnose or mislead you. But children with CF, they will have pancreatic insufficiency, and they will have evidence of malabsorption for the fat. So the pancreatic insufficiency that will face us, more than 90% of CF patients, protein and fat malabsorption, there will be vitamin A, D, E, K malabsorption, and there will be beta cell function decrease with age, but it will be sparing the endocrine part. So the incidence of malignancy later in increase, and that will be another challenge for those patients. So earlier we started, it is a multidisciplinary. So I will involve our colleague in the pediatric pulmo. I will involve the ID for the frequent infection and catabolism here. Nutrition is a major key to be supportive for those patients, that they need enough diet that have enough amount of calories. The GI, because we look for failure to thrive or complication, as well as the abdominal distension and so on. And then the social worker, because they need enough financial support. So from the challenge that facing me here, and this is what will be ending our talk, the number one globally or in the Gulf or in the Middle East or any developing countries, compliance. Number two, early referral of those patients. And number three, the availability of medication. So compliance is a problem because it's a chronic disease. So there will be many missing appointments that we can face in our offices. The medication availability, now we in the era of the COVID, of the enzymes, coenzymes and the creon and so on. So we may have a shortage, although the kingdom tried their best to have these medication available all the time, but that's another thing. Third part is the early diagnosis. Many of those patients go to the primary care physicians and they will be either missed or they will be over or under treated. So awareness of the primary health worker, awareness of our colleague in general pediatrics about the commonicity of the cystic fibrosis in the Middle East will make early referral, so the multidisciplinary people will be in charge. So one major problem, we said, the medication and the pancreatic enzyme replacement, the vitamin replacement, as well as the early diagnosis, so we can help those population. Then consequently, we can prevent what I mentioned in the liver lecture about the end-stage liver disease and the transplantation and the chance of malignancy later in life. So nutrition part is the major challenge. How can I give them enough calories for those undernourished population? So they need at least twice the recommended daily requirement for age, because we need to sustain a weight gain. Majority of those patients I follow in my office, more than 30 to 40, with my colleague in the pediatric pulmo, there is major problem is they are underweight, either third or fifth percentile. So we need to have enough caloric intake. Those population, they need to have enough fatty food from butter, from margarine, from mayonnaise, from heavy cream, whole milk, and so on. So we encourage them to have this kind of food when they need to eat it. So the amount that will come from snacks or from ice cream or flavored flavored food. Protein, at least twice the daily requirement. The fat, for at least 40% of the calories should come from fat. Vitamins, we should not forget about the vitamin. The major challenge facing us in the Saudi Arabia, we don't have the ADIC as one tablet, so we have a separate like A, D, E, and K. It may be available in Bahrain or available in Kuwait. Some family, they will bring it or buy it, or some they can get it through Amazon or through the overseas. Sodium and sodium loss, we should have enough salt added to their formula because they need to prevent these things. Losses. Usually the enzyme replacement, it's up to 90%, they have pancreatic insufficiency. So they should have the form of the enzymes in enteric coating pills. They should swallow it and take it as recommendation by the physicians with the snacks as well as with meals, but never take generic enzymes because we don't know the bioavailability and so on. Infants need adequate calories. Children need adequate lipase, and all children, they need more, and so on. So it depends on the age and so on. Creon, it's the second smallest microsphere. There is creon 5, 10, and creon 20. 5 refer to 5,000 units of lipase per capsule. Creon 10 means 10,000, 20 means 20,000. There is a pancreas also for 16 and 20. You multiply it by 1,000, so that will give you the units of lipase. There's another one called ultrase, and there's ultrase the higher percentage. So these are the available enzymes. These available enzymes are available in the kingdom, so on. If the patient is at a maximum dose and still symptomatic, that's another challenge facing us. The mom comes to your office, say, Wallahi, I give him as you tell me, but he still has steatorrhea, he's not gaining weight, there's abdominal distension, and so what shall you do as a physician? Then you may need to use an acid blockers like PPI. You know, the H2 blockers is off market now. So I will use either omeprazole, esomeprazole, or pantoprazole. I can switch a brand of the enzyme. So if they are ultrase or pancrease, I may put them on creon. Then the adherence, and that is a challenge that also with the snacks and drinks, they should have adequate amount of those enzymes. What else can cause loose stools? That's when they come to our office as a gastroenterologist looking for infectious or related disease I showed you early, like celiac disease or IBD. I hope I'm still on time. Treatment is to initiate it as soon as possible because fat and fecal elastase, they may need the H2 blocker I told you. And the problem facing us with the higher dose of the pancreatic enzyme replacement is something called fibrosing colonopathy. Fibrosing colonopathy, and because there is no limit, so family using more often in regards of the physician recommendation, so they may have end with a stricture in the colon, especially with high dose of enzymes, and the enzyme will get to the colon and causes damage, so there will be scarring and stricture. We don't see it much in pediatric, but maybe in the long, because now the survival rate of the CF patients is beyond when I was trained in Iowa 30 years ago. The survival was, I remember one of the patients I followed, he was 18 and he died. So now the survival rate is in the 30s and maybe in the 40s, and from the GI point of view. So we may see fibrosing colonopathy in adult population more than in pediatric population. So make sure the dose of the enzyme replacement should not be high. There was a question asked about ursodiol and the ursodeoxycholic acid that will increase bile flow and decrease the toxicity of bile acids, and that will depend on what is going on with the liver and the hepatic system here. Liver transplant is the curative only if there is portal hypertension or the severe liver damage. Now, related issue here, which also we miss or we may challenge our practices, is the bone disease. Those patients are at risk of vitamin D deficiency, so they are at risk of rickets, osteoporosis, osteopenia, so there will be more risk of bone fracture. So we need to make sure they have adequate amount of supplement of vitamin D, and there should be an adequate, frequent or annual DEXA scan for the bone, so they need an extra biophosphonate and so on. If you are worried about the intake and the adherence and the compliance, we may use tube feeding here, and we may use some special formula that will help adequately increase the nutrition in those population. I will skip these slides because enough talk about transplant. Now the psychosocial part is another challenge. We live in a community that I will say we believe in God, like any other community. We believe in al-qada wal-qadar. So some people say, okay, my kid is sick, so what can I do? So they will miss appointment and they will not come, and so that will result in poor quality of life. There is a burden on the family, frequent hospitalization. There is a burden on the morbidity and hospitalization. There's a burden on the finance, especially if they are not insured. Alhamdulillah, in the kingdom, the patients are fully covered by the government insurance. So there is not issue, but if it comes for the burden of traveling, some of the population come far away. You talk about 400 to 500 miles away, and some they will need to stay in a hotel, and so that's affect the quality of life, affect the family, affect the planning. So there may be a problem with adherence to therapy. There will be a problem with the family planning itself, and so on, missing school, and so on. So we should not miss that the psychosocial issue is an important part in those populations. I will end in the summary here, as mentioned earlier, and will be in the next few sessions after me. It is an inherited monogenic disorder with multisystem disease. The pathophysiology here is mainly because of the ion transplantation across the epithelium. GI, pulmo, GU are mainly affected, and the treatment is mainly preventative and supportive until gene therapy will be and final solution for this problem. There are similarities between both the GI and the respiratory. So my colleague in pediatric pulmo, they will not say we are the first. We are both the first. And so pulmo and GI have the same similarities between the two diseases. CFTR will cause pathology in both by obstruction, infection, and inflammation. The animal models and the technique used to explore one system will lend insight to the other system. And the treatment right should be focused mainly on how we can modulate the CFTR, how we can improve the GI, how we can improve the respiratory tract function, so we can have a better survival and better outcome for those population. This is slides where I was practicing in Boston before I came to Saudi Arabia 6 years ago. Thank you so much, and it's a pleasure to be with you. Thank you, Prof. Adel, Prof. Basil, and the organizing committee.
Thank you very much, Abdelhai, for a very comprehensive overview of the CF-related gastrointestinal issue. One of the questions that's coming across here that do, in terms of compliance with treatment, what percentage of patients attending your clinic would you consider as compliant with therapy?
This is a good question, really. I mean, looking around, we have around 30 patients. We are a referring tertiary center. I will say 25% non-compliant. They missed appointments, but I will give them an excuse because they live far away, around 200 kilometers from our center. So when they give the appointment, most of them, they may not show up. Add on, Prof. Basil, the COVID and the Corona limited the transfer for those populations. So even the compliance through the era of the COVID went down even more than 75%. So we're mainly managing through the phone, but roughly a quarter of them have an issue of compliance. And we always stress on that we need those populations to be with us.
I think that's a very, it's a universal issue all across the world. And the previous speaker and the speaker we will have tomorrow, and I'll urge everybody to attend, about what could be the new normal in CF care management in terms of remote monitoring. And using the phone, or most of the people now through their mobile devices, I think that could help in a way, but a hybrid model rather than just a one model may be the answer. Are there any issues with access? That's an international person. Are there any issues with access to enzyme replacement therapy?
You know, because another good question, because that's another adherence. The enzyme, we have shortage, and there are many times it depends on the producers and the way. So problem happening, patients are many times on the Creon, and because there's shortage, they will be replaced by Ultras or pancreas. So that frequently of changing medication may affect the outcome. There was a problem, again, during the Corona and the COVID. And many times we are lending some of those enzymes from other facilities, like the military hospital or Aramco and so on. So it is a problem. It is a major challenge, absolutely.
Okay.
Dr. Abdelhai, sorry to interrupt. We know, thank you so much, Dr. Abdelhai, for the presentation, but how can we, one of the challenges actually that we face regionally here and nationally probably, is how can we involve pediatric gastroenterology in the loop of the care? Not, to be honest, not all of them, they are really interested. It's few of pediatric gastroenterologists, they do believe that it's a shared care. Some of them, they don't believe even the disease exists, and it's purely, if it is there, it's a pediatric pulmonary issue. So how can we tackle this? How can we solve this problem? Because as you said, it's a shared care between both of us, gastroenterology as well as pulmonology.
Well, I'm glad you brought this question up. I'm glad, really. Not only Prof. Kingdom or the Gulf, even in the States. I was in both, in Boston at Tufts as well as Harvard. And very limited people from the GI like to be involved in the CF. I don't know if it is time consuming or it needs more time to sit with those patients. So that's number one. Number two, they believe some of the gastro, it's not a common disease. So why I need to focus on 1% of the total population that come to my office with other related diseases. Number three, from insurance point of view, luckily in the Gulf, we have, as I mentioned, government, but the private insurance may not give enough money or time to the physician to sit with those population. So I saw, you're absolutely right. I saw many of the gastroenterologists are not interested. You gave me an assignment to talk to many in the Saudi Arabia, and really out of more than 10 people, I did not feel any of them interested. So the question comes, how can I get them share and come? I think by inviting, hopefully, inshallah, the corona will go over and we can have some more like conferences and invite them directly, or go through the societies. Gastroenterology Society, we have a big one in the Saudi Arabia called Susbigan. There was a big one in the Emirates. There is one in Egypt and one. So for those people with gastro, they can be the messenger to send a message to the gastroenterologist that this disease is existing. Great. And it's a rewarding. And this disease can help those population. Absolutely, I agree with you. It is a problem.
I think it is, and you've put in some answers there, which hopefully will be followed, and something that we can take over as one of the messages from this conference. Thank you, Dr. Abdelhai, and much appreciated your time. Thank you.
Welcome. Thank you so much. Thank you. I appreciate it. Assalamu alaikum.
Our next speaker.